Hello, hello. Can you hear me?
Yes, sir.
Okay, thank you. Good afternoon, everyone. Good afternoon.
Good afternoon, sir.
Yeah, today I'll be discussing with you all adult orthodontics. First of all, we'll see the content of the topic, introduction, history, and the comparison between adolescents and adults, objectives, classifications, adjective orthodontics, comparative orthodontics, and lastly, retention. As you all know, what is adult orthodontics? The orthodontics is the correction of malocclusion, which is done in adults. Adults means, as you know, there will not be any growth remaining. There is some the growth, which means the patient at the age after 40 years of age group. First, we will see what is the biological concepts associated with adult orthodontics. First is periodontal ligament, bone, and the teeth. So these concepts means the periodontal ligament, what are the status of the periodontal ligaments in the adults and the bone and the teeth. First we will see periodontal ligament. As you know, periodontal ligament is comprised of fibroblast, which is a blood-borne origin, and these are originated from the pleuropotential cells. These collagen fibers and pleuropotential cells are present in the periodontal ligament space. As you know, as the patient age advances, especially in the old age group, the turnover rate of these collagen fibers will change. Usually, turnover rate will be 2.5 to 6.5 days, but as age advances, the turnover rate, that is the reorganization of these cells, will take more time, which means, hello,
Yes, sir.
can you able to see the screen?
Yes.
Okay. So next will be the proteoglycans. The main function of these proteoglycans is to withstand the occlusal forces, and the water, which is the water content in the periodontal ligament space, also changes as the age advances. Which means in the adults, especially the fibroblast cells, the reorganization which is takes place in the adolescence and the organization takes place in the adults is different, which means the fibroblast reorganization is reduced in the old age. There is, if any tear or wear in the periodontal ligaments will take more time in adults compared to the adolescents. And the prostaglandins, which is present in the periodontal ligament space, are responsible for resorption of the bone, which means the bone resorption is more in the adults than the adolescents. Next is the capillary bed, which is nothing but a number of branches of the blood capillaries are present in the periodontal ligament space. But as age advances, the blood capillaries will decrease. The number of blood supply also decreases. Nerve tissue. What happens to the nerve? As the age advances, the number of neuroreceptors also decreases, and the sensory responsiveness also decreases. Next, coming to the bone. What are the changes in the bone we see in the adults? The mechanical properties also decreases, the strength of the bone also decreases, and the macroscopically, macroscopically, the trabecular bone volume also decreases, which means the bone volume decreases and the property, the strength of the bone also decreases. Osteoblastic activity, osteoblastic means the bone formation activity also decreases, which means the bone deposition process also decreases as age advances. Sinus size increases means the more number of porosities increase. Bone, as I have said, bone density also decreases. There will be the imbalance between resorption and bone replacement, which means the more will be the resorption and and the less will be the bone replacement, so that there will be more of resorption than bone deposition. Next, coming to teeth. In teeth, there will be the more root exposure, as you can see, due to gingival recession, and there will be a short crown root ratio, which means the crown exposure is more than the root, and the center of there will be a center of resistance will be shift more towards the apex. As the bone resorption takes place, gingival recession, due to which the center of resistance shifts to the apex. You can see in the second image, the center of resistance will be shifted more apically, when we can see the bone more will be the bone resorption. Or in some cases, if there is a root resorption, in those cases also center of resistance changes. And even in a diameter of the pulpal canal also reduces as age advances. Vascularity and innervations, that is the nerve supply, also decreases, and there will be a reduced pulp recovery. So these are the things you can see in the adults, which means as you have seen periodontal ligament, there is a less of reorganization of fibroblast, and there is a less blood supply, less nerve supply, and the bone will be a more fragile, the, the bone density decreases, and in the teeth you can see more of root exposure, and there is a more of bone resorption, and there is more chances of root resorption. So these are the problems we'll see in the adult patients. So now, why it is so important for us? Because when you are treating adult patients, you should know what are the changes we see in the tooth, in the surrounding structure, that is alveolar bone and the periodontal ligaments. So these are the problems in adults. Now coming to the history part. In 1880s, as early awareness of orthodontic protection for the adult patients. It was long back in years, hundreds of years ago. There is awareness in the adults for the orthodontic treatment. But later in 1901, McDowell has said that it is impossible to treat orthodontically in the old days. But as time advances, Lister has told me optical age for the treatment of orthodontics, which means, according to Lister, he said it is a golden age of treatment. Case has been said in 1921, the value of adult orthodontic therapy. Riedel has said the orthodontics is total discipline and it makes no difference whether the patient is young or old, which means orthodontic treatment can be done in any age group. There will not be any age specification. It can be done in young as well as old age. Previously, orthodontic treatment used to be done in ancient years also. It used to be done to correct the malaligned teeth or to replace the missing tooth, to align them, to derotate them, to replace them. So it is not done nowadays. It is since long time the orthodontic treatment is done in adults as well. Now we'll see how the graph. What is this graph is showing? The adult practice. We can see here in 1970s, the treatment which is the adult patient were taking is around 3%. After 1975, there is an increase in the demand of the uh, orthodontic treatment in adults. In 1980s, again 15%, in 1985, 20%, in 1990s, 25%. With this graph is showing there is the patients are more interested, especially adult patients are more interested in taking orthodontic treatments. The number of patients are increasing. Now question comes, why do adults seek orthodontic treatment? Why adult patients take orthodontic treatment? One reason will be did not want orthodontic treatment as children, which means when they were in children they don't want orthodontic treatment. That's why they are seeking orthodontic treatment later, or they did not know about orthodontic treatment as children. They did not know about it when they were children. Parents could not afford orthodontic treatment as children, or no orthodontist located in their vicinity when younger. Incomplete orthodontic treatment as children, or they may be non-cooperative at that time. They had some orthodontic treatment as children, but in some cases they might have got relapsed, or more conscious of appearance with age. Means with advancing age they may be becomes conscious about their appearance, or there may be some position teeth contributing to PDL diseases. Means periodontal diseases may be contributing to malposed teeth, or there may be spacing appearing between the anterior teeth and it is enlarging day by day, or maybe some new spaces opening up. So these are the reason why adult patients seek orthodontic treatment. Now we'll see what is the main comparison between the adolescents and adults. Adolescents is the age group is 20 to 40 years, whereas adults, according to Profit, adults may be above 40 years. So we are discussing here the adult treatment who are more than 40 years of age. Now we'll see what is the main difference. We'll see the dental caries first. The dental caries is more susceptible in adolescents, but whereas in adults, there will be root decay and pulp pathosis. Coming to the pedial diseases, their, their resistance to bone loss, susceptible to gingival inflammation, but whereas in adults, they're susceptible to bone loss, which means there is more bone loss in the adults, but whereas in adolescents, there is more resistance to bone loss. TMJ adaptability is high in the adolescents, means if there is any TMJ disorders can be corrected in the adolescents, but whereas in adults, symptoms with dysfunctions. There may be some symptoms with TMJ disorders. Occlusal awareness is infrequent, it is less common, but whereas in adults, there is increased enamel wear with adverse changes in supporting tissue. Next, growth factor. In adolescents, orthopedic appliances can be used and which is more stable. Whereas in adults, no growth potential. So only treatment option will be the surgical. Rate of tooth movement is hello. Rate of tooth movement is rapid in adolescents, whereas in adults it is slower. Orthopedic appliances 50%. We can in the adults we cannot use orthopedic appliances. Orthognathic surgery very less amount required, but whereas in adults 10 to 20% of cases requires orthognathic surgery. Restorative dentistry very less smaller amount, whereas in adults is more frequent. In combination treatment it's uncommon, whereas in adults it is 80%, which means we may have to do surgical procedure as well as and prosthetic procedures. Next, encourage potential. In adolescents, we may use headgears, but in adults, we may have to use implants because in adults we cannot use headgear and face pose. Missing tooth, space closure without prosthesis can be done in adolescents, but whereas in adults, we have to give restoratives or prosthesis. Extraction controversy. Mostly four premolars are most commonly done in the adolescents, whereas in adults it's very less frequent. Next, coming to adult orthodontic treatment objectives. There are mainly three objectives. One is dentofacial aesthetics. The adult patients seek orthodontic treatment for the aesthetic reason mainly. First, our consideration should be for aesthetics. We have to give better aesthetics. And stomatostatic function means the function should be normalized. And the stability. Stability is whatever correction has been done that has to be stable for the patient. So these are the three main objectives. As I said, normal occlusion is the fourth objective which has to be maintained. There are some additional adult orthodontic objectives. One is parallelism of abutment teeth. Means if we are placing any prosthesis, we have to see to that the abutment teeth should be parallel. Most favorable distribution of teeth, all teeth should be in the in or should be favorable. Redistribution of occlusal and incisal forces, they are inclined such a way that the force should be distributed equally. Adequate embrasure space and proper tooth position has to be maintained. Adequate occlusal landmark relationships, better lip competency and support, improved crown root ratio, improved self-maintenance of periodontal health. So these are the additional objectives of adult orthodontics. Now we will see one by one. Parallelism of abutment teeth. As you know, when there is any missing tooth, the adjacent tooth try to incline in the or incline into the extraction space. In these cases, we cannot place abutment or prosthesis. First, we need to upright the inclined tooth. That the adjacent tooth has to be uprighted, has to be made parallel. Then we can place an implant. This is most commonly seen in adults because missing tooth due to missing tooth, so that it will help in the placement of the prosthesis. Distributed evenly by replacing. If any teeth are missing in the occlusion, has to be replaced, and the teeth has to be uprighted, and the prosthesis has to be replaced. If any spacing rotations are there in the occlusion, they has to be aligned properly. Then prosthesis will be placed to maintain the normal occlusal forces. Next, adequate embrasure space and proper root position. The root positioning has to be done uprighted, so that there will be a favorable uh, distribution of the forces. If required, we have to place restorative materials due to caries or proximal cleaning should be adequate for the patient. Next, adequate occlusal relationship, which means if any crossbite is there, that has to be corrected, especially anterior crossbite has to be corrected. And in some cases, there is skeletal crossbite cases, only anterior crossbite can be corrected because skeletal corrections are not done orthodontically. Next, we have to see better lip competence in support. In case of anterior restorations, if there is any incompetency due to prosthesis, that has to be corrected by retracting the anteriors. Inadequate support, change in anterior posterior position or vertical position of the upper lip, and increase in the wrinkling. Improved crown root ratio. In case of bone loss, we have to intrude the tooth sometimes, we have to extrude the tooth sometimes to maintain the crown root ratio. Better self-maintenance of the PDL health. Improved self-maintenance of PDL health occurs with proper tooth position. The proper root positioning has to be done so that PDL should be maintained. And teeth should be positioned properly over basal bone so that it will increase its life of the tooth. Aesthetic and functional improvement. It should provide acceptable dentofacial aesthetics and improved muscle function, normal speech and masticatory function. Coming to the classification of the adult orthodontics. According to Graeber-Wennestal, corrective orthodontics, it means any crowding or spacing has to be closed and crowding has to be relieved and aligned. This comes under corrective orthodontics. Adjective orthodontics is nothing but it is an adjective procedure for the placement of the prosthesis or any other procedures. Orthodontic treatment will be given for helping for the placement of the prosthesis, especially uprighting of posterior teeth or intruded tooth can be erupted, forced eruption of the any anterior or posterior teeth, alignment of the anterior teeth, crossbite correction. These comes under adjunctive orthodontics. Orthognathic surgery is nothing but a surgical procedure is done after the orthodontic treatment. Coming to the goals of adult orthodontics. What are the goals? Facilitate restorative treatment. Is facilitate restorative treatment. Next, improve periodontal ligament health. Next, favorable crown root ratio. So these are the goals of adult orthodontic treatment. Next, coming to principles. What are the principles? The first principle will be the proper diagnosis and treatment planning has to be made by collecting adequate data, developing a problem list. First, we have to collect that data by taking a proper case history and examination. Next, we have to write down the problem list. What are the problems present in the oral cavity? Then we have to make a diagnostic reports. First will be you have to take a OPG or sometimes you may have to take full mouth IOPs, lateral self, you have to take photographs, take impression and make a dental cast. These are the record has to be taken and evaluated. Next, biomechanical consideration. Characteristics of the orthodontic appliances. So when after doing all the treatment planning, problem list, everything, so what are the biomechanical consideration before giving any appliances? What are the things we have to consider? First is encourage control. As you know, in adults there will be less number of tooth, there will be less bone remaining, or more will be the bone resorption, or there will be a mobile teeth. For that, we need to correct any malocclusion, to correct any tooth position. We need to have anchorage. From where do we get anchorage? For that, we need to consider the anchorage. How we are going to control the anchorage? We may have to place implants sometimes. We may have to take the tooth which is more stable. So encourage consideration is an important thing. And second, the appliance, the bracket which you are placing, which type of bracket you are placing, whether it is edgewise bracket or vex bracket, that has to be considered. Next, next is whether we have to use a removable appliance or the fixed appliance. And then bracket placement, where we are placing our bracket. As you know, there will be a change in the crown and root ratio. For that, we need to decide where exactly bracket has to be placed. When there is a more of bone resorption, we may have to place bracket more apically than incisor. So these are the things we need to consider before starting the case. Encourage, what type of encourage, appliance, what type of appliance, whether it is a removable or fixed, and the bracket placement where we are supposed to place. If any single tooth rotation or any single tooth correction is required, we may have to give removable appliance. When multiple tooth are supposed to be corrected or then the posteriors are supposed to be uprighted, we may need more force. In those cases, we may have to go for fixed appliances. Say in this case, the molar is mesially inclined. We may have to upright this molar, or these premolars are rotated. We may have to correct these rotations. For these things, we have to use fixed appliances. Next, effects of reduced periodontal ligament support. What happens when the annular bone is resorption? of the alveolar bone takes place, due to which there is a center of resistance, as I have said already, center of resistance shift more towards the apex. For that, the force applied should be less, and the bracket positioning is more towards the apex, not at the incisal edges. So this has to be considered before placing brackets. We have to see whether there is a bone resorption, whether there is change in the crown root ratio, that you have to be considered before placing the brackets. Now coming to timing and sequence of treatment. In adults, mostly we see periodontal disorders, any other diseases related to gingiva, or any diseases related to systematic disorders. First, you have to see, does patient is having any active disease, gingivitis, periodontitis, any active diseases. This disease has to be controlled first by doing scaling or by giving any taking consultation from the specialist. Then patient has to be re-evaluated to see established occlusion. Once the occlusion is established, then we have to do definitive restorative treatment if required. It may be a prosthesis, it may be filling, it may be placement of implants. Next is the maintenance. Whatever corrections has been done, we have to maintain that. We have to stabilize the occlusion. These are the sequence of the treatment, especially in the adults. Next, coming to adjunctive orthodontic treatment procedures. As we already discussed, uprighting of the posterior teeth, especially in the missing tooth, when the missing tooth, adjacent tooth will incline in the extraction space. It has to be uprighted, especially molars and premolars. Force eruption and alignment of anteriors. So these are the adjunctive orthodontic treatments. How the uprighting will be done? Say this molar is mesially inclined, we can upright it by giving a bend in the wire, and you can place in the molar tip so that it will apply distal mesial root movement and distal crown root movement, distal crown movement. This is how we can upright the molar. In the figure A, it can be done by mesial crown movement or distal crown movement. In this case, you can see there is a uprighting of the molar, that is distal crown movement and mesial root movement. And force eruption in some cases due to trauma or due to ankylosis, some incisor may be infra-erupted. In those cases, you can bond the infra-erupted tooth and place a continuous arch wire, nita wire or elastic. By this we can extrude the tooth, single tooth extrusion. Alignment of the anteriors, especially in the old days, there will be a appearance of spacing between the incisors, canines, laterals. In those cases, we can place a bracket and they close the space. You can see in the last image, the space has been closed. In some cases, there will be an increasing diastema space. This can be closed by placing elastics. In the crossbite, anterior crossbite or posterior crossbite can be corrected by the use of elastics. The last part will be the retention. Once any correction, it may be a force eruption, it may be uprighting, it may be derotating, it may be space closure, anything. After correction, all that, we have to give retention. It can be removable or fixed. Retainers, polish retainers, tooth positioners, spring retainers. In fixed retainers, it may be bonded or banded. These are the holly retainer can be given after the orthodontic treatment. These are the positioners, aligners. It's also called as aligners. These are the acrylic aligners. And the fixed retainer, it can be used given lingually or labially. You can see these are the retainers after correcting the crowding or spacing. Just coming to cases, there are some cases, red cases which have been treated. You can see in this case, there is excluded incisor, there is a spacing, there is periodontal problem. You can see there is a proclination. You can see there is a bone loss, gingivitis. All these things can be seen in adults. Intraoral picture you can see fluorosis, bone loss, all the things. But this case has been treated by placing bracket and the space has been closed. You can see in this, all the space has been closed and alignment is done. This is our intraorally pre-surgical phase. You can see in this, lower alignment has been done. All the rotation has been corrected. And this is done in two phases. One is orthodontic and second is surgical. The mandibular advancement has been done in this case surgically. This is how post treatment. The retraction has been done, space is closed, incisor intrusion is done, and surgical mandibular advancement also done. You can see comparison photo. This is the pre-treatment and the post-treatment. You can see improved profile. Incisor has been retracted. Alignment is done. We can appreciate the changes in the face. So this completes adult orthodontics. So mainly I would like to say here, the adult, it's very difficult to treat adult patients because there is so many problems in the adults. There will be a gingival recession, there is periodontal problems, there is plaque, calculus, there is mobility, there is bone loss, and there may be some systematic disorders. All these things will be there in the adult patients. And there is many missing tooth. So very difficult to treat adult patients. But mostly, before starting any treatment, first you have to see, you have to do thorough clinical examination, make a list of the problems, what are the patient problem, and you have to explain, you have to write the objectives. So first what we are doing, and later what are the procedures are required. Then take a patient consent and start in step by step. The once treatment is done, the most important part is the retention phase because chances of relapse is more. For that, we need to give retainers. The patient is asked to wear retainers regularly, and immediately after the treatment, the required other treatment, such as prosthesis, such as restorations, has to be carried out immediately. We cannot leave them. If it is delayed, after correcting alignment, after uprighting the tooth, if we delay in the placement of prosthesis, there is a chances of relapse. So by this, I would like to conclude my presentation on adult orthodontics. Students, if you have any doubts, you can ask me. Hello?
No doubt, sir.
No doubt, sure. Hello?
Um, I want to ask up
Yeah,
to
yeah.
what age we can do orthodontic treatment on adults?
See, there is no specification for the age group. Okay, there is no specific. We can do it after 50 years, even after 55 years. Provided we have to see there is a bone support for the tooth. If there is a bone support, then we can do treatment at any age group. Even after 65 years, also we can do it. But patient has to maintain oral hygiene properly. If alveolar bone support is there, gingiva is healthy, then we can do treatment at any age group. There is no specification.
Thank you, sir.
Thank you. Any doubts?
No.
Okay, thank you everyone. Thank you.